1 minute, so we start. Okay, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. So I'll be the chairperson for today, and I'll be just introducing all the speaker today. Basically, Dr. Hassan is our registrar for internal medicine department, and the next presenter will be Dr. Zainal Abdullah bin Zainal Adlishah. He's basically our graduates before internal medicine masters also, but he's now a physician and also palliative fellow from internal medicine department. And Professor Madya, Datin, Dr. Shahizon Azura, my Sifu from also consultant neuroradiologist, and Dr. Badrul Iskandar bin Abdullah is our pathologist for today, and he'll be presenting and sharing the case with us. And last but not least is our colleague from oncology, Dr. Nur Faizah Abdul Muin. Okay, so before we continue the program, kita mulakan dengan bacaan Ummul Kitab Al-Fatihah. Alhamdulillah. So without further ado, I'll pass the platform to Dr. Zainal to then facilitate Dr. Hassan for this presentation.
Alright, Assalamualaikum warahmatullahi wabarakatuh, and a very good morning. So I hope everyone is ready for some discussion on the case on a topic entitled "It Begins with the End." Later on, towards the end of the presentation, I will explain a bit on why we choose such topic. So, Hassan, are you ready for the discussion today? Yes, boss. That's good. All right. So, let me introduce the case to you, and we go with the discussion later on. So, this is a lady in her late 30s with no known medical illness, presented with chronic headache for the past 1 month, associated with slow response, confusion, and forgetfulness. According to the husband, she had multiple episodes of vomiting and facial asymmetry for the past 2 weeks prior to presentation. She was also weaker and has been ambulating less. She also had loss of appetite and prominent weight loss, but not quantified. No significant chronic illness previously, except she was under orthopedic follow-up in another center for chronic back pain for the past 6 months. Upon examinations on presentation, her GCS was 15 out of 15. Still obeys simple commands, but appears lethargic. Vital sign was stable. She was febrile. Neurological examinations show no cerebral signs. However, we notice right cranial nerve 7 palsy or facial nerve palsy. Power examination showed 3 out of 5 for right upper limb, 4 out of 5 for right lower limb. Plantar reflex was upgoing for right side. Other examinations other than this was unremarkable, right? So, what further history would you like to ask for this patient, and what investigations would you like to order, Dr. Hassan?
So, this is basically a patient who have presented with chronic headache and also constitutional symptoms with a previous history of chronic back pain. First, I would like to ask whether there is a fever, chronic cough, and also do you have any family history of TB contact, or family history of malignancy? Any other neurological symptoms, such as she do presented clinically. She have neurological symptoms, which is weakness. However, I need to ask which is the timeline of the weakness, and then also any drug history also involved. Okay, whether this is drug induced for this lah.
How about investigations? Anything that you want to send at this initial?
The first thing that I want to send is for the diagnosis. I was thinking of some sort of infections, and also possible with the constitutional symptoms is possible space occupying lesions. So the confirmation of the diagnosis will be the lumbar puncture, and also other blood tests, lumbar puncture, to see whether there is any TB such as CSF TB gene experts, or also other biochemical parameters, whether there is any bacterial meningitis or viral meningitis. Then I would like to send the blood investigations to formal blood investigations such as full blood count, whether trace total white cells, liver function and renal function test, ESR and also CRP. And so for sputum culture also can be sent because constitutional symptoms for TB, sputum AFB. And for the imaging part, I'd like to do further workup with CT brain or KIB MRI brain.
Okay, all right. So let's have a look on what was done for this patient. So additional history, as you asked, Dr. Hassan, there's no history of prolonged fever prior to this presentation. She did have intermittent cough for the past few months, but somehow never actually seek proper medical treatment for the cough. She was unsure of PTB contact, but to her knowledge, no known family members diagnosed with PTB previously. No family history of malignancy. She had MRI spine done previously, but she was unsure about the result. And blood investigations, this is the basic investigation that was done on the presentation to our center. The white cell count was 17.7, the hemoglobin was 14.2, platelet was 537. The renal function and liver function was fairly normal except elevated ALP. The electrolytes were normal, actually. She actually came from another center. She presented to a different center first before coming to us. So she had a CT brain done in that center. However, unfortunately, we did not get the images, but we did get the formal report of the CT brain. But before that, if I forget, this is her chest X-ray. And any particular abnormality that you want to point out that for the benefit of the students here, Dr. Hassan?
From this X-ray, I can see there's multiple opacities or consolidation seen over the right middle zones, right upper zones, and left upper zones areas. Costophrenik angle was okay. There's no pleural effusions, no cardiomegaly also.
Right.
Dr. Zainal, sorry to disturb a bit, because for the sake of medical students and those that just arrived, so maybe just a bit of summary. Then Dr. Hassan, can you just share with, because the medical student, right, they are junior doctors, what run inside your mind in terms of the current situation, the possible diagnosis? Dr. Zainal, give the summary for a while first. Okay.
So, just for the benefit, summary again. A lady in her late 30s presented with confusion, headache, and forgetfulness for the past 1 month. And then started to develop facial asymmetry and weakness for the past 2 weeks, and some vomiting episodes. On further history, she has prominent weight loss and loss of appetite for the past few months, and has been having intermittent cough that was not being taken seriously and did not seek any further medical treatment for the cough. So she presented mainly with headache, confusion, weakness, vomiting episodes. And examinations reveal right-sided weakness indicating upper motor neuron lesions. So, Dr. Hassan, what's the differential diagnosis at this point, perhaps?
So it is subacute to chronic presentations. My thought process will be more like those infections causing subacute or chronic infections such as TB meningitis. Any bacterial meningitis also can, if not treated. Then I'll go with the constitutional symptoms. I'm thinking of malignancy or space of focal lesions. Since the patient is young, so I was thinking also in the process of autoimmune such as SLE. Yeah.
Do you have any rheumatologists in-house that might not agree with that or else? Okay, all right. So this was the chest X-ray, Dr. Hassan. So this is the CECT brain that was done in another center that I mentioned to you. We don't have the images, but you were given a report from the center that mentioned multifocal left cerebral hypodense lesions with faint enhancement and leptomeningeal enhancement. Cerebral abscess and meningitis need to be considered. So this is the report by the radiologists in a different center. Of course, in any situation, we need to correlate the imaging findings with the patient clinical findings, the symptoms, the history and all. So at this point, you have mentioned your differential diagnosis now. After all this basic investigations has been acquired, what further investigations would you like to do to confirm the diagnosis? I know you mentioned lumbar puncture initially. Unfortunately, in this case, due to unforeseen circumstances, it was initially delayed and subsequently was cancelled. I'll explain later on why it is cancelled. But we don't have lumbar puncture in this particular case. So any other investigations that you would want to order now to ascertain your diagnosis or what's going on in this patient?
From the, I already mentioned the sputum cultures, sputum VFVs. Next, we will proceed after the CT scan will be the MRI brain to confirm the diagnosis. If I think we have to, lumbar puncture is one of the thing that key investigation to diagnose meningitis. So I think I'll try to push it.
All right, okay. That's a good thought. So even when your patients or the family member has doubt on it, has what we call it, family members undecided. Isn't that the usual commentaries or reason that we put in the documentations? So you can always repeat the counselling so you can get the lumbar puncture to be done. So let's go with the initial differential diagnosis, because of course for this patient, the advanced imaging will take some time. So differential diagnoses were made and treatments were initiated. So as you mentioned, this was the differential diagnosis that was given initially on the presentation of this patient. Number 1, disseminated TB with TB meningitis. Number 2, multiple cerebral abscess. Number 3, cerebral opportunistic infections or cerebral metastasis. So at this juncture, we have started him on empirical treatment. Perhaps can you suggest to us what would be the empirical treatment that you would start for this patient?
So if we thinking of in the route of disseminated TB, more likely is more like disseminated TB with TB meningitis. I will start in on anti-TB medications such as Acurit or any all 4 tablets. And also in view of TB meningitis, probably I'll start on some dexamethasone based on the confusions. Better.
How about abscess?
Abscess. If you can start also antibiotics for that. Antibiotics such as ceftriaxone or acyclovir and acyclovir.
Right. So, Dr. Hassan, perhaps if we, for the benefit of the students, we can let them know how does treatment of TB meningitis differ with your usual, or not usual, basically the common PTB. How does it differ? Perhaps you can let them know.
So one is the durations of the antibiotics, the anti-TB medications. Usually it's longer. It's up to 9 months. And then also, if there is any confusions, grade 2 or grade 3, usually we add on dexamethasone, steroids to cover for the for the brains. Yeah.
So in treatment of CNS TB or TB meningitis or TB spine, usually the duration it can go even up to 12 to 18 months for the anti-TB. Indeed, this patient was started empirically on anti-TB and also on IV ceftriaxone 2 gram BD, which is the CNS dose, to cover empirically for infection. Subsequently, we could not proceed with LP in this particular case. As you mentioned sputum screening. She cannot produce any sputum. You mentioned infective screening. It was done. Everything was negative. So these are jumps images of the MRI brain. Just a slip through. Later on, we'll have a detailed explanation by our neurologist. But any particular striking feature here, Dr. Hassan, that you see?
There is hyper intensity over the left thalamus, left temporal regions. Over the left thalamus here, left temporal region and left occipital region, also left frontal regions, hypo intensity noted. Yeah.
Would you call this rim enhancing lesions?
Rim enhancing lesions, yeah.
Right. Okay. So we will go into details later on. So just to add on to this case, we actually managed to trace the images from another center that did the MRI spine previously. So I'll just show the images. For this particular image, I won't let Dr. Hassan explain it because we will have our radiologist later on to give us details about what should we see in there. But if you can just see, this is the MRI spine, a snippet of the MRI spine that was done for this patient. All right. So without further ado, I would like to invite Professor Madya, Datin, Dr. Shahizon to deliver her thoughts on this.
Assalamualaikum and a very good morning to everyone. So I'm here to present the radiology segment of this presentation. Okay, imaging-wise, we received a request to do MRI brain following an abnormal report of CT brain having multiple ring-enhancing lesion and a diagnosis of likely brain abscesses with meningitis was made. So MRI brain was requested to further assess this lesion. Just an overview, this is a T1 post-GAT with flare post-GAT. Just a series of images to demonstrate that there are multiple lesions. Majority of the lesions are ring enhancing, and you can see the lesions in the infratentorial as well as supratentorial area, and there are evidence of leptomeningeal enhancement as well. What is the difference between T1 post-GAT and flare post-GAT? Flare post-GAT is a sequence that is superior to assess leptomeningeal disease. As an example here, you can see a lot more of enhancement in the cerebral folia here, in the posterior fossa, as well as the sulci enhancement, which is better seen here on the flare post-contrast. Now let's have a look at some of these lesions in detail. I'm going to concentrate on the lesions that were ring enhancing, mainly in the thalamus as well as the high parieto-occipital area. Let's concentrate on this lesion here on the thalamus on the left side. You can see that it is heterogeneous on T2 weighted as well as flare. When it is heterogeneous, it means that the content of the lesion consists of perhaps combination of solid lesions, solid nodules, fluid, blood, calcification, and so on. In this case, you can see some high signal foci on T1. There are a few things that can return high signal on T1. Mainly, they are blood, fat, or calcification. And if you see that this lesion that has high signal, it returns low signal intensity on T2. This is quite consistent and quite characteristic of a blood product. A fat would usually not be hypointense on T2. And it is ring enhancing, and it's quite heterogeneous. And if we see the lesions in the high parietal region, you can see that there is rim enhancement. The wall is a little bit thick, and it appears nodular. These are the features that we normally see in neoplastic lesions. Okay. For ring enhancing lesion, there is one sequence that is very helpful and can help us to decide what the lesion is. It is DWI and ADC. It is always interpreted as whether there is restricted diffusion. What it means by restricted diffusion would be it will be high signal on DWI and low signal on ADC. There are a few things that can have restricted diffusion. We see this a lot in infarction, in infection, as well as in abscess. In this case, if we look at the ring enhancing lesion, it demonstrates peripheral restricted diffusion, reflecting the area with rim enhancement. It has high signal on DWI and low signal on ADC. And more importantly, the center of the lesion demonstrates facilitated diffusion. What it means is just that the water can sort of like moves freely. And we see this in usually neoplastic lesion. In pyogenic abscess, the center usually would be dark, it would be black. Another sequence that is helpful in this case is susceptibility weighted imaging, whereby it is superior to look for blood product as well as calcification. And here we can see punctate microhemorrhages. Okay. We see this again mainly in tumors. Sometimes we do see this in abscess, but in pyogenic abscess, the hemorrhages usually would be seen as a complete rim at the area of enhancement, rather than neoplastic lesion, whereby it will be punctate, incomplete rim, and it's haphazard in appearance. Showing you the leptomeningeal enhancement. So these are the enhancement that you see. It sort of like coats the midbrain, as you see in this case. And I'm just demonstrating the difference between leptomeningeal enhancement and a normal sulci. So there is no enhancement here on the right side. In contrast, on the left side, you can see a lot of enhancement in the sulci. So in summary, we have here multiple ring enhancing lesions. They are randomly distributed, mostly at grey-white matter junction, meaning indicating that this is probably hematogenous spread in pattern. And it has irregular nodular outline. And you can see leptomeningeal enhancement. They are smooth. Microhemorrhages on SWE. And the diffusion weighted imaging showing that there is peripheral restricted diffusion with facilitated diffusion at the center. So these findings are most consistent with hemorrhagic brain metastasis, and the possible primary is from the lung, the kidneys, choriocarcinoma, melanoma, thyroid, and breast sometimes. So we have a mnemonic for ring enhancing lesion. The differential diagnosis for ring enhancing lesion is a magic doctor. So there are quite a few here, but we are going to concentrate mainly on METs and abscess and how to differentiate between the two. So both will have ring enhancing lesions, but in metastasis, majority of time, it will be irregular and nodular. And the leptomeningeal enhancement, again, it can be smooth, but once you see nodularity, it points more towards metastasis. And the DWI and EDC is basically the main important sequence to differentiate the two, where in pyogenic abscess, you will have central restricted diffusion. I'm stressing here it's pyogenic abscess because non-pyogenic abscess can also have facilitated diffusion, as an example in cases of toxoplasmosis or in fungal infection or in tuberculomas. So we have to look at other features that can support this diagnosis. What about the SWE? SWE, you will have incomplete hypointense rim on METs and a complete hypointense rim on pyogenic abscess. Now let's have a look back at this chest X-ray that was showed earlier. We see multiple lesions and they are mainly distributed in the apical segment of the upper lobe. When we see this, in our setting, majority of time, if it's infection, it's TB. But in TB, usually it will be consolidation. Consolidation, you will see some abronchogram, which we don't really see here. It looks like a mass-like appearance. And, well, I think this one needs to see a lot more for you to appreciate this, but I hope you can see that there are actually extra lines here. I'll show you on CT later on. So what does the CT show? It's a mass because you don't really see any abronchogram or cavitating lesion. There are multiple. And in bone setting, here we can see a lot of septal lines. So these lines are lymphangitis carcinomatosis. We do not see this in tuberculosis. And if you look at the the spine, in bone setting, we see a lot of sclerotic and lytic lesion distributed along the spine. Again, I hope you can appreciate this. Can you see that there is actually a lytic lesion here? And if you look at this vertebral body, comparing it with the rest of the vertebral body, it looks a little bit sclerotic. It is difficult to assess the spine on chest X-ray But usually we can do so if you have PACS, you have to play around with the window width and window level. So in this patient, it's concluded that the patient has a bronchogenic carcinoma with brain and bone metastasis. So the take-home message, I think, for this case, CT usually is the first line imaging modality for CNS disease. But when you have positive findings on CT, please do MRI, because on CT, when you see ring enhancing lesion, it is not very specific and cannot tell you what it is. If the clinical history doesn't fit to infection, you really have to investigate more, and you will have to do MRI for further evaluation. And for infection, specifically for abscess, you will see central diffusion restriction. And for non-neoplastic lesion, usually it will be, for neoplastic lesion, usually it will be central high signal. I think that is all from me. Okay.
Thank you very much, Prof. Shahizon, for the excellent input. So I guess there's a lot that we can learn from the MRI. But of course, as you mentioned, generally, I guess, especially those in medicals, when you have a young patient presented with constitutional symptoms, CNS symptoms, no other history, has a bit of back pain, and then intermittent cough that is not very well defined, chest X-ray like that, the initial thought that came was actually disseminated TB, which is primary TB with that's known can easily involve the brain and also the spine. So, Dr. Hassan, after we got the input from the radiologist just now we have achieved our diagnosis. Left lung malignancy with distant metastasis, isn't it? So what's your next step for this case?
Next I would like to get a CT guided biopsy for tissue diagnosis lah. In view of the left lung malignancy, I'd like to refer IR for CT guided biopsy. That's the best options, I think.
Any other method if, let's say, not eligible for IR?
Can refer RESPI for either, if it's more central, you can do a bronchoscopy or for biopsy. EBUS, and also if there is any other lesions or lymph nodes available, probably we can do biopsy on those also.
All right. Okay. So it's very important when you suspect or when the diagnosis of lung malignancy or any kind of malignancy is made, we need a tissue diagnosis. So we did proceed with CT guided biopsy for this case. And for the next one, I would like to invite Dr. Badrul Iskandar from our anatomical pathologist to present on the histopathology examination of the lung biopsy. Please welcome.
Okay, Assalamualaikum and good morning, everyone. So I will be presenting the histopathological examinations of the lung biopsy for these patients. Okay, so this is the few cause of lung tissue. Okay, so where it is infiltrated by these malignant cells, as you can see over the red circle here, where the malignant cells are arranged mainly in cords and in small clusters. And there is also a residual normal lung tissue adjacent to this biopsy. So on further magnifications, so the malignant cells exhibit enlarged, as you can see here, nuclear enlargements. Pleomorphic means it has a variety of sizes, some with prominent nucleoli, as you can see over here. There is a small nucleoli within the nucleus, and there is a occasional mitosis. And within the surrounding stroma, you can see there is a mixed inflammatory infiltrate, which mainly lymphocytes, and there is a desmoplastic response. This is just a normal lung tissue for reference. So this is how a normal lung tissue looks like, where it has alveolar septa, thin alveolar septa with spaces, where this thin alveolar septa is lined by the pneumocytes and there is an occasional alveolar macrophages over here. So from this case, so there is a melanin cells infiltrations, and it is arranged in cords and clusters, and it is enlarged with hyperchromatic nuclei, and some appear polygonal in shapes. So from this, what are the differential diagnoses as from the pathological perspective? Of course, first I'm thinking of squamous cell carcinoma, because squamous cell carcinoma tend to have polygonal in shapes. This is the example of squamous cell carcinoma. So it can arrange in clusters and shades. Other than that, adenocarcinoma, particularly in moderately to polydifferentiated adenocarcinoma, where usually it lacks of glandular formations and it tends to become more solid and clusters. Other than that is neuroendocrine carcinoma, particularly a large cell neuroendocrine carcinoma, also may have a similar morphology, which is it is arranged in sheets with enlarged pleomorphic nuclei. And lastly, of course, I'm thinking of metastatic carcinoma, where it could be from the breast, from the colon, and etc. So how I would like to differentiate these differential diagnoses, of course, we need to do the immunohistochemical stainings. So what are the immunohistochemical staining that helps in this case? First is the thyroid transcription factor 1, which is the TTF1, where this immunohistochemical stainings is help to differentiate whether this is a primary or is it a metastatic from the non-lung primary tumors. And at the same time, it also can help to differentiate between whether is it adenocarcinoma, where TTF1 usually expressed in adenocarcinoma as compared to squamous cell carcinoma. Other than that, it also can be positive in thyroid malignancies. Next is nepsin A. Nepsin A is also helps in this case, as nepsin A usually overexpressed in case of adenocarcinoma, which is about up to 92%, and in squamous cell carcinoma usually is negative. And it also can be positive in endometrial or ovarian clear cell carcinoma and also papillary renal cell carcinoma. P40 is also helpful, especially is one of the differential is squamous cell carcinoma, where usually it is positive in case of melanin cells with squamous differentiations. And lastly is synaptophysin or chromogranin, which these are the neuroendocrine markers. So in case like neuroendocrine carcinoma, it is expected to be positive for synaptophysin and chromogranin. Other neuroendocrine marker that can do is the INSM1 or CD56. So for this case, this is the TTF1, which is positive. As you can see, there is a nuclear staining of the melanin cells. And this is the nepsin A. So you can see it is a cytoplasmic and membranous positivity of the nepsin A. And I also did a P40, which is a squamous marker, but it is negative. As you can see, the nucleus, this is the background staining, which stained blue, and expected to be positive, it is a brown colors. But in this case, it is negative. I didn't do synaptophysin and chromogranin for this case. Usually, I will reserve synaptophysin and chromogranin if the TTF1 and nepsin A is negative. So because of TTF1 and nepsin A positive with this morphology, so my diagnosis is adenocarcinoma, likely from lung primary. So I think that's all for me. Thank you.
Dr. Badrul, sorry, just to, for the sake of medical student, when the first slides just now, when you share, what do you expect if you put it for exam?
This.
Yeah. Just the next slide. I think, yeah, this one. Will you put it for exam, and what do you expect if the undergraduate exam?
Usually, this case is moderate to poorly differentiated. So usually for exam purposes, we usually put well differentiated, where you can see a glandular formation to say it is a adenocarcinoma, because from these images, it's quite difficult and to say it is adenocarcinoma per se. As you can see, the arrangements of these malignant cells rather it become more solids and cluster instead of glandular formations. With this kind of morphology, it has a few differential diagnoses that I mentioned earlier.
Thank you, Badrul. So basically, the mitotic figure or this looks like neoplasm kind of thing. The keywords as usual for histopathology.
If this kind of morphology, what we can see is just a malignant cell infiltration or just a polydifferentiated carcinoma, something like that. We cannot ascertain whether is it a squamous, is it a adenocarcinoma, or is it a neuroendocrine carcinoma without immunohistochemical staining.
Thank you, Badrul.
All right, thank you very much, Dr. Badrul. So, what will be your final diagnosis now, Dr. Hassan?
My final diagnosis will be lung adenocarcinoma with metastasis.
So, okay, so this is the final diagnosis for this patient. Is a left lung adenocarcinoma with distant metastasis. Before we go into a bit more details on the management of this particular diagnosis, any idea what are the different perhaps treatment modality that you know that we can use or we can approach in the case of lung adenocarcinoma? It's a bit more modern compared to the conventional ones. Okay.
Tyrosine kinase inhibitors, TKI. The chemotherapy regime, I think better oncology consultation.
Okay. Any names of TKI that perhaps you remember?
Imatinib. Yeah, no, sorry.
But not for lung CA. A lot, isn't it?
Not a lot.
Okay. So as Dr. Hassan mentioned, there's a lot of options of tyrosine kinase inhibitor that can be used as targeted therapy in lung adenocarcinoma. And for that, I'm not the right person to talk about that. So we have our last panel, which is I would like to invite Dr. Nur Faiza Abdul Muin, our radiotherapy and oncologist, to present her thought on lung adenocarcinoma management, and particularly related to this case. Please welcome.
Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to fellow colleagues, professor, and also students especially. So today I'm going to talk about lung adenocarcinoma, specifically focusing on a very important group, which is young, female, non-smoker, and we'll talk about challenging metastasis to the leptomeningeal. So I hope for the students, by the end of this talk, we will gain some understanding in terms of epidemiology of lung adenocarcinoma, recognize the risk factor beyond just smoking, and appreciate the atypical symptoms of leptomeningeal metastasis, and we will move on to gain some basic idea about treatment modalities, particularly in targeted therapy, especially in this case for brain metastasis and leptomeningeal metastasis. So as we know, lung cancer actually remains the leading cause of cancer mortality worldwide. The main histological subtypes, I think Dr. Badrul has mentioned, but usually we will see adenocarcinoma, squamous cell carcinoma, as well as small cell carcinoma. So today our focus is adenocarcinoma. So in terms of epidemiology, over the last few years, there is interesting shift in terms of increasing incidence of cancer in never smokers. About 10 to 25% of lung cancer actually occurs in never smokers. And the key group affected in this group is actually higher proportion in women of younger age, less than 50 years, and Asian populations. And because majority of the time we don't expect it to occur in this group, it is under recognized and most of the time delayed in diagnosis. So what are the risk factor beyond smoking? Actually, I classify into two. It could be environmental exposure and as well as occupational exposure. For nowadays, there are more thoughts that this could be contributed to the air pollution, particularly the fine particulate less than 2.5 micrometer, because this is so small that it can deposit deep into the lung and cause irritation. So this is the main thinking currently, as well as second hand smoke, indoor air pollution, cooking oil fumes, biomass fuel exposure. In terms of occupational exposure, radon is an asbestos known factor. So radon is actually not so much in Malaysia. It's actually radioactive gas emitted from the stones and soil. Usually it's affected in poor ventilated area, especially in overseas kan, dia ada basement, so that usually the area where if the earth exposed or emitted this radon gas, then it would be higher risk. Arsenic, nickel and chromium is actually heavy metal, so usually workers that involved in welding, heavy metal factory at more risk of this. So where does this cancer, especially adenocarcinoma metastasis, usually they metastasis to the brain about 30 to 40% of the time. So nowadays when we have lung cancer, we usually will include CT brain or MRI brain to actually stage them. Bone metastasis also is common, 30 to 40%, liver as well as adrenal gland. And interestingly, for patients that have this certain mutation, which we call EGFR and ALK mutation, they have higher risk of metastasis to the CNS. So in terms of leptomeningeal metastasis, so this is considered CNS metastasis, but it actually spreads to the lining of the brain, to the pia mater and arachnoid mater, as well as the CSF fluid. So basically it can actually also present in the spinal regions. We call it as a drop mats. So the incidence is about 3 to 5% in lung cancer overall, but it can rise to about up to 15% in EGFR mutated lung cancer. So what are the symptoms? For leptomeningeal metastasis, it's actually usually subtle and atypical. So it is coined as the great neurological masquerader because of these non-specific symptoms. And it often led to delayed diagnosis because of these non-specific symptoms. The symptoms usually can be because of, can be presented as two types, cerebral symptoms, usually because of increased intracranial pressure, such as headaches, nausea, vomiting, cognitive decline or seizure, or due to cranial nerve, present as cranial nerve deficit, such as diplopia, facial weakness or hearing loss. So what are the prognosis? The prognosis is poor in general. Untreated, you can have overall survival, which means their lifespan is about 4 to 6 weeks. With treatment, historically about 3 to 6 months. Nowadays, with targeted therapy, it improves, may extend to 12 to 18 months in selected patients. So what are the treatments? In general, in lung cancer, we will depends on the molecular status of the tumor. So molecular stainings and further NGS testing is actually very pertinent in management of this cancer. We also will have a look at the patient performance status. Usually we will use ECOG performance status 0 to 1, 2, 3, 4, and then excess of the CNS disease. The main treatment modalities usually for cancer in general, we have chemotherapy, we have targeted therapy, and then we have immunotherapy. This is all systemic therapies. For localized metastasis, sometimes we use radiation therapy, which is called radiotherapy. So for this specific case, I will focus on targeted therapy as well as radiation therapy. So in terms of molecular profile in this young non-smoker group, they have different mutation from the smokers' lung cancer. So usually their mutation harbor actionable driver mutations, which means we can target them. And the common mutation that we see are listed in the table, so such as EGFR, epidermal growth factor receptor, ALK rearrangement, ROS1, RET, MET exon 14 skipping, or KRAS G12C. So the common one that we see in Asian population, fortunately, is EGFR, about 40 to 60%. ALK rearrangement is a bit less, 5 to 10%, and the rest is about less than 2%. So the target, this mutation is actually, nowadays we have medications in the form of, majority of the time is oral tyrokinase inhibitor. So there are multiple medications and generations of TKI now available. For an example, in EGFR mutations, we have the most common that we use in this hospital, usually gefitinib. This is the earlier generation and the cheapest one that we have. Nowadays, it costs about 500 ringgit Malaysia. And the most current one for EGFR mutation is osimertinib. So osimertinib is actually the best and the one we should aim for. However, cost is always an issue. For reference, actually osimertinib, one box for 1 month costs about 30,000 ringgit Malaysia, but there are patient-assisted program for patients to actually help with this medication. It's not actually funded by the government. For ALK, we have several other options like crizotinib, ceritinib, alectinib, and lorlatinib. So the newest one is the lorlatinib, and the rest as stated. So, so in terms of CNS penetrations, not all TKI works the same to the brain. So usually for brain penetration, the best options for EGFR is osimertinib. For ALK, we will use electinib, or nowadays we will aim for lorlatinib because the evidence for CNS metastasis is excellent, as listed below, and entrectinib for ROS mutations. So that is for systemic. For role of radiation therapy mainly is for local disease. So for brain metastasis, we can offer whole brain radiation therapy, which means you give the radiation to the whole brain. Usually will be used for multiple brain metastasis, especially if patient is symptomatic. Focal radiation, which means you give to part of the brain where the brain metastasis evidence. So as the name suggests, it is limited to a limited number of brain metastases. If the volume permits and the locations permits, we will push for high radiation therapy such as stereotactic radiosurgery or gamma knife, which we have in HUKM. So in terms of leptomanager metastasis and role of radiation therapy, I put up here actually a survey that was done in European country to say that, to actually portray what are the real world practice. Actually, there are certain differences. So this survey actually look at 115 physicians, included in that pool is 19% of radiation oncologists. So they don't actually support routine use of whole brain radiation therapy, but they select the patients. About 15.5% support select. Only 15.5% support routine whole brain radiation therapy. So majority actually preferred whole brain radiation therapy to the patient that have multinodular disease. Why is that? Because whole brain radiation therapy, when you give, it will impact patients' brain functions. They can have sometimes memory impairment. So we try to avoid this if possible. So then we think about focal radiation therapy. So for leptomanageal metastasis, sometimes the symptoms does not correlate with the MRI finding. So what we will try to do is, if there is correlations, then that what we will target in the radiation field. And it is portrayed also in the survey. So, this is what? Okay, I think that's the end of my talk. Yeah. So, in conclusion, I think nowadays the prognosis of patients with lung cancer, especially the one that have targetable mutation, and they have the capacity to actually proceed with this new treatment, especially the one that crossed the blood-brain barrier, the prognosis is better, and we will try to initiate the treatment with systemic therapy as quickly as possible. Thank you.
All right, so following this diagnosis, let's have a look at the progress of this patient with us. The patient actually complained in ward, subsequently complained of worsening back pain despite on regular tramadol. She became bedbound in ward. The ECOG status is at ECOG 4. For the medical students here that would like to read further, we have a performance status assessment. In cancer patients, we call ECOG, where we grade the patient from 0 to 5. So bear in mind, ECOG 5 is dead. So she's at ECOG 4. So that was her status. So Dr. Hassan, she's been complaining of worsening pain in the ward. They've been given her regular IV tramadol. Doesn't seem to work. How would you manage this patient, and what would be your main focus now?
To address this, her conditions now is actually ECOG 4, bed bounce. The prognosis is not great. So therefore, I'd like to address the symptomatic treatments. The back pain, actually, if she can tolerate early, we can start her on syrup morphine and have palliative referrals to see her conditions. Any other options includes, if no, fentanyl also. Other than that, oxycodone. Yeah.
Okay. So indeed, for these patients, we was seen with the palliative team. We off the tramadol and we switch her to oral oxynom. Just to give a highlight on a bit of pain management in cancer patient. This is just a one-page summary from the American Society of Clinical Oncology recommendations, which is similar with our own CPG, in line with our CPG. The core treatment options is to offer opioids to moderate to severe pain. This is a bit different than conventional pain management, where your moderate pain, you would use either your NSAIDs or your weak opioid. In cancer pain, you can always go to strong opioid from the get-go when you have a moderate to severe pain. And you start low and titrate frequently. You need to plan for breakthrough pain. And when we mention opioid here, the choices that we have here in HCTM would be morphine, oxycodone, and fentanyl. We also have methadone, but that would be under the purview of palliative team in selected cases, right? You have to proactively manage adverse effect from the opioid itself. Be cautious in patients with renal impairment, and you have to collaborate with patients with substance use disorder. You might need to involve your addiction specialist from the psychiatry team and whatnot. These are the common side effects: the constipation, nausea and vomiting, and also sedation. But remember, the adverse effects are not contraindication for using opioid. It is something that you have to manage even more preemptively, especially in constipation, while using opioid for these kind of cases. So, to summary, for this unfortunate lady, subsequently she became more confused with reducing consciousness and worsening dyspnea in ward. The opioid was switched to continuous subcutaneous infusion. The patient then passed away while surrounded by her loved ones. So this was the end of the story. The reason why we brought this topic with such phrase of "it begins with the end" is because this was her first encounter with us. This was her first admission to our center, but this was also the end for her relationship with us. And so sometimes we can't really save everyone, and indeed in life there are challenges. In medicine, there are challenges that we need to overcome in the future, but that doesn't mean we cannot treat the patient despite the grave diagnosis. I would like to end this presentation, the sharing today, with this quote from Patch Adam. You treat a disease, you win, you lose. You treat a person, I guarantee you, you will win no matter what the outcome. With that, I thank you, everyone.
Thank you, Dr. Zainal. Thank you, Dr. Hassan. Thank you to all the speakers. And I think, this call slides really conclude where, I was thinking the same thing. So basically, we cannot win each time when we treat a patient. And the first thing, because of I'm called the chairperson today because I encountered this patient where we need to ask what the patient really wants, what the patient family really wants. So the patient wanted the pain to be treated well, and the patient need to be comfortable. The diagnosis is actually the family, they want a closure, and we get a diagnosis too. Okay, so with that, thank you everyone, and continue our work and also study today. Okay, Assalamualaikum warahmatullahi wabarakatuh.